Good evening, good afternoon, and good morning, depending on where you are. Welcome to the IPVS and APAC HPV Correlation Educational Webinar 2025. My name is Patravut Watanasak from Khon Kaen University, Thailand. I'm currently serving as the president of the Asian Society of Head and Neck Oncology, and it is my great honor to be the moderator for the entire program today. And as we know that the HPV is one of the leading infectious agents causing cancer worldwide, and head and neck cancer has become a global issue, health issue, especially with the rising incidence of oropharyngeal cancer around the world. This trend has significantly changed the way we approach the disease, and both in medical practice and from a public health perspective. So today we have a great opportunity to learn from the well-renowned speakers in Asia-Pacific region. So we are honored to have professor from Taiwan, United States, Japan, and Korea, and also myself to run as a moderator, that we can share their insights and perspective on the HPV-related oropharyngeal cancer. And we will take you on a journey through the HPV-related OPC, covering the epidemiology, clinical presentation, updated management, and regional insights from the different countries. And to achieve on the learning objective, I encourage everyone to actively participate in this program. We have a Q&A session, which will take place at the final of the program. So I hope that you all will learn that with our speakers. Okay, so now we're going to start with the lecture. We have two speakers for the two lectures before we have the panelists. And I would like to take this opportunity to introduce our first speaker. She's the head and neck surgical oncologist at the Johns Hopkins School of Medicine, where she leads the Division of Head and Neck Surgery and Head and Neck Cancer Center. She's also directs the Head and Neck Group at the Bloomberg Kimmel Institute for Cancer Immunotherapy. So today he's gonna talk about the perspective on HPV from infection to malignancy, implications for the epidemiology and clinical presentation of HPV-related OPSCC. So Professor Carol Faegre, the floor is yours.
Thank you for the introduction. So I'm going to talk about the epidemiology of oropharynx cancer and how that relates also to the epidemiology of oral HPV infection and what the clinical implications of both are. So as many of you know, head and neck cancer has really evolved in recent decades. To the left is kind of the typical, face of head and neck of the past, which was really primarily driven by smoking and alcohol. And in recent decades, this has changed in terms of our patients and causes of cancers. The incidence of oropharynx cancer is increasing around the world, and these incidence trends are most prominent among men and more recent birth cohorts. In the US, using population-based data, what you can see is that the incidence of the risk of being diagnosed with an oropharynx cancer has increased significantly in recent decades and recent birth cohorts. So if we look here, the risk of being diagnosed between the age of 55 to 59 for men has been increasing significantly over recent decades, whereas if you look at the risk for women, it is very attenuated and flat. So this is really, these trends are really among men and recent birth cohorts. We see similar trends around the world. This is data from the Neil Shedder-Veddes group, where they compared it to lung squamous cell cancer, which is primarily driven by tobacco. And when we use that comparison, we see that there are inverse trends for oropharynx cancer and lung cancers really around the world and among men and in recent cohorts. We believe that this is attributable to coronavirus, which is common infection around the world. When we look at these trends among men, this is work by Zach Zumstead and Anil Shettervedi looking at trends around the world. What we see is that incidence has really increased recently in about 19 countries. And so we see that oropharynx cancer is increasing globally, and not just among men now, but we are now starting to detect that there are differences among women. So in this story of HPV driving incidence of oropharynx cancer started almost 2 decades ago. It was really among men, and now we are starting to detect differences among women. And these differences, these increases in oropharynx incidence for women have been detected in 23 countries in this analysis, and they're geographically distinct from men. It is thought that these increases are arising where there is high human development index, and so there is a correlation both among men and women with human development index. While HPV is responsible in large part for these trends, I point this out to show that there is geographic heterogeneity in terms of the attributable fraction of HPV. This is work by Hisham Hanna's group, and this was a multi-institutional, multinational group. And what they showed is that HPV is responsible for a greater proportion of cancers in certain parts of the world than in others. When we looked at this in the United States, what we've seen is when we look at tumor samples over time, that HPV is increasing both among men and women. We look at P16, which is the indirect way of measuring HPV status, and we look by in situ hybridization, it is increasing. And while initially when these incidence trends were, initially pointed out men and whites, what we are also finding, in addition to the story of increasing trends among women, is that it is increasing across the race groups. So when we test samples in multi-institutional studies in the United States, among non-whites, we see similar trends as with whites. So HPV is increasing in oropharynx cancers across the groups. And while initially described to be a tumor that was arising in young individuals, when we look at trends across the age groups, we see that HPV is increasing across the age groups. In fact, when we look at the median age of patients with HPV oropharynx cancer, it is increasing over time. Both when we look at data at Johns Hopkins, and then on the right panel is nationally representative data, we see that the median age is increasing. When we look at the population level, this is data again from Zach Zumsted's group, we see that the incidence is increasing in older age groups as well. So HPV is responsible for these trends. This is data from our earlier case control study that was led by Maura Gilson. And what we see is that sexual behavior and oral HPV infection in the case control study were strongly associated with the diagnosis of oropharynx cancer. And this was early data to demonstrate that oral HPV-16 is strongly associated with oropharynx cancer in addition to E6 and E7 seropositivity, so the antibodies to the oncogenic infection. So we now know that oral HPV infection is the precursor to HPV-related cancer. So a little bit about the epidemiology of oral HPV. This is data from Neil Shettervedi and Maura Gilson using NHANES data, which is US representative population data. And so when you sample individuals with oral rinses to detect HPV, what you see is there's a bimodal distribution for HPV. And so you see that there's an earlier peak around the 20s, and there's a later peak around age 50. And similar to the cancer incidence data, you see that the prevalence of oral HPV is higher among men than women, and you see that it's also bimodal among men. There is a dose response increase of prevalence with increased number of sexual partners, showing that HPV prevalence increases with increasing number of partners. When we look at the type distribution of HPV in oral rinses in healthy participants in the US, what we see is HPV-16 is the most common. While it is the most common, it's still relatively rare. Only 1% of the population have HPV-16 in oral rinses. We know that cigarette, current tobacco use is also associated with increased risk of oral HPV-16. And so prevalence increases in stochastic fashion also with biochemical and self-reported measures of tobacco use. And so this is thought to be a strong risk factor for oral HPV infection and persistence. I think one thing I want to point out when we think about oral HPV infection versus the HPV types that end up in tumors. When we sample healthy individuals in oral rinses for HPV, we find that there's a broad HPV type distribution, which is on the right here that you can see. So HPV-16 is responsible for a small subset of all the HPV types that are oncogenic, meaning those that go on to develop cancer or have the ability to develop cancer. But then when we look at pharynx cancers, what we see is that HPV-16 is responsible for the lion's share of cases of oropharynx cancer. It is also interesting that this distribution varies by age. So HPV-16 is more common among younger individuals with oropharynx cancer as compared to older individuals who have non-HPV-16 types. And this is consistent between data here that we looked at in the at Johns Hopkins and UCSF. And when we compare it to data from the Princess Margaret group, median age for non-HPV-16 oncogenic types was higher than for HPV-16 tumors. So what could this tell us? One of the hypotheses we have is that HPV-16 is just more likely to persist and more quickly develops into cancers than non-HPV-16 types. So we looked at natural history studies to really understand what the risk is of having an oral HPV infection, developing cancer, into a persistent infection, and going on to develop cancer, and what that timeline looks like. We have limited natural history data in oral HPV infection. We have lots in genital HPV. So this is data from a study from here from Hopkins that Amber D'Souza and I have run. We have a large study of healthy individuals that we've been following really for the past 10 years. This is a subset of the data that involves healthy individuals who have HIV or are at risk of having HIV. These are individuals who are at increased risk of having oral HPV. So we followed individuals over time who had oncogenic oral HPV infections. And this helped us to see over time what happens to infection. And so we followed these individuals and sampled them at regular time periods. And these are all the individuals who had started and had an oncogenic oral HPV infection. And what you see is that most people clear their infections over time. However, after 7 years of follow-up, about 20% still had an oncogenic HPV infection. So what are the risk factors to help so this suggests clearance of infection? So if we sampled someone at the beginning of the study and they had an oral HPV infection, that was more likely to persist. So they were less likely to clear that infection. New infections that come and go, so incident infections, were more likely to clear by the end of the study. HPV-16 was less likely to clear than non-HPV 16 oncogenic types. So other oncogenic types were more likely to clear by the end of the study. And then men were more likely to have a persistent infection. And then older individuals were also less likely to clear their infections. This is consistent with data from Anna Juliana's group, where they looked at healthy individuals without HIV and looked at oral HPV over time. And what they found is that HPV 16 clearance was delayed relative to the other oncogenic types. You see here that there's a longer tail for HPV 16, and the median time to clearance was much shorter for the non-HPV 16 infections. And what we found is that we followed people with oral HPV 16 over time. This is looking at it by viral load, with hot red being the highest viral load. We see that this is really a precursor of really microscopic disease of what's going to come. So we see that we can follow people over time. And then here's one person who had been consistently red, who went on to develop oropharynx cancer. And those who were more likely to clear had negative infections. And so they had kind of flickering of infection over time. So what this tells us from a natural history perspective is that we can identify people who are at risk of developing oropharynx cancer, and that oral HPV DNA is a biomarker that's non-invasive. It's very easy to collect. It's just a rinse and a gargle. And that persistent oral HPV 16 DNA may be a risk factor for oropharynx cancer. On the other hand, we think that it has probably low predictive value and low sensitivity, and it's unclear what the follow-up would be. So what are the other biomarkers for development of HPV oropharynx cancer? I shared earlier from the case control study that E6 serology was strongly associated with the diagnosis of oropharynx cancer, odds ratios up in the 60s, and some studies even higher than that. And this is data from Amy Kramer's group, and she's shown several case controls and case cohorts over time, one with Tim Lauterbohr's group at DKFC, that E6 seropositivity precedes the diagnosis of HPV-related oropharynx cancer by several decades. And so you see that it's robust and that the titers are stable over time. And you see that some people go from being seronegative and cross over into being seropositive before they develop their cancer. Dan Faden at MGH with the Broad Group has developed ctDNA methods. And so in addition to serology, which is blood-based, assaying for circulating tumor DNA, we can find in case control studies that HPV is detected in the blood years before the diagnosis of oropharynx cancer. And so this tells us that we might have a potential screen for HPV-related oropharynx cancer well before the time of development of clinical manifestations of cancer. So what are the early screening studies that we have available that have read out essentially? Eric Sturgis, who is at Baylor in Houston, Texas, has a Houston study, and this was a study that he had done at MD Anderson to screen men between the age of 50 and 64 years of age. He used HPV 16 antibodies and oral HPV detection to identify individuals who are considered to be at risk for development of HPV-related oropharynx cancer. And those who were biomarker positive were invited into a longitudinal study where they were followed over time. So they started with 553 men, went down to 47 men, and they found one individual who had failed to come back and follow up, but after enrollment did develop, just clinically, oropharynx cancer. So really they found a prevalent cancer. And then they found several anal dysplasias among men who were either E6 seropositive or had oral HPV 16 DNA without E6 seropositivity. There was also a study in Queensland, Australia, where they used oral HPV 16 DNA to enrich for a population that was at increased risk. So they found Among 665 individuals, they found 9 were oral HPV-16 DNA positive. And then those who were persistent after their initial visit were invited for an examination. And among those 3, they did find 1 early oropharynx cancer. And then they found 1 with dysplasia, although I would just point out that dysplasia is not a recognized entity for HPV positive cancers. And then they had 1 who had a normal exam. In a study that Tim Waterboard from DKFC did within a screening study for anal cancer, among those who were E6 seropositive, which can also hearken an anal cancer, they found 1 oropharynx cancer, so it had been a prevalent cancer. The individual was deceased by the time they followed up with them. And then they identified 1 early oropharynx cancer as well. And so these might be helpful in the future for secondary prevention, but we're still a really early state in terms of studying which assay to use, understand what the pre-malignant state is, what the clinical workup would be. And so how does this help us in the surveillance setting? So there's a lot that we can understand when we think about the biomarkers being a precursor for preclinical disease. And how do we apply that to our patients who have finished curative treatment and might be in surveillance? And so can we think about the same detection methods of oral HPV DNA or plasma, circulating tumor DNA, to think about how we survey those patients? And so this is oral HPV DNA detection during treatment, after treatment, and just shows that it is a biomarker of disease. In patients who are getting chemoradiation therapy, if we look at their oral HPV DNA week to week, you see that there's a reduction in prevalence of tumor DNA. And if you look at it in terms of viral type, viral load, and you look at the tumor-specific type, you see that it goes week to week during radiation therapy, from high viral load to low viral load, and it clears by the end of treatment. This is really specific to a tumor type infection. So if someone has a tumor type that is not related, someone has an HPV type that is not related to tumors, or non-tumor type infection, so it's true, but unrelated to their tumor, those viral loads remain stable during treatment. And the identification of the tumor type HPV infection in an oral rinse after treatment is associated with worse survival, overall recurrence-free, local regional-free survival, and a trend towards distant disease, although it is not a good sampling for that. And we see that oral HPV DNA in the surveillance setting, just like in the screening setting or natural history data, is identified before the clinical manifestations of disease. And then we look at circulating tumor DNA. This is data from Shamshera's group. We see that identification of plasma HPV in the surveillance setting is strongly associated with worse survival. And so really the question is, how do we test? What assays do we use? Is it blood? Is it saliva? And then how do we test for it? Do we do ddPCR, which is what Shamshera's group data was based on, or do we use next-gen sequencing, which is the data that I showed you from Dan Faden's group at MGH? We know that the sensitivity differs by the different sampling types and the different technologies that we use. This is data from Inori's group, where they did a study looking at circulating tumor DNA using NGS, and what they found is the presence of the assay was strongly, of biomarker was strongly associated with worse survival. So hopefully that gives kind of a window as into the next talks in terms of the clinical implications of it. Why is it not ready for prime time? The lead time between positive test and recurrence is unknown. I would also say that the lead time between a positive test in the screening setting and clinical disease is also unknown in a prospective, robust fashion. The risk-benefit ratio of doing this testing is unknown. The frequency and the type of testing is also unknown. And we really don't have large world studies in terms of performance characteristics. So in conclusion, hopefully I have shared a little bit about the incidence trends of oropharynx cancer, how they're evolving. When we had first described this disease, it was really increasing incidence among men, younger age groups, and now it is expanding to women across the age groups and across races. And while it had been really a disease that was really focused on the Western hemisphere, it is now increasing around the globe. And then hopefully the key insights of natural history that I've shared with you in terms of oral HPV DNA and its persistence and development to oropharynx cancer also gives some insight into surveillance amongst our patients who are successfully treated for oropharynx cancer. So thank you, and I will pass it on to the next speaker.
Thank you very much, Professor Carroll, for your wonderful talk and giving an understanding of from the oral HPV infection to the oropharyngeal cancer, and there are the tools that we can use for the surveillance. I hope that you can stay, that we can maybe discuss after during the Q&A session. Yeah, let's move on to the management. This time, it is our great honor to introduce the second speaker, Dr. Nancy Lee. She's a radiation oncologist with over 20 years of experience specializing in head and neck cancer. And she's also a leader in the field with the advanced technologies. Yeah, and certainly a lot of study research that's involved clinical trials to focus on the safer and more effective treatment, especially for the HPV-related cancer. So today, she's going to talk about the de-escalation strategies in HPV-related oropharyngeal squamous cell carcinoma. So please welcome Professor Nancy Lee.
Thank you so much for a kind introduction. I think everybody can see my slide, right? I just want to make sure. Okay, yes. So yes, my topic today is looking at the escalation strategies for HPV positive oropharyngeal, specifically. Dr. Carol Vakri just talked about HPV infection, surveillance, and it's timely to talk about the treatment. Now, as a radiation oncologist, we're no different than surgeons. We have a lot of toys. On the left, you see we have every toy you can name, and ranging from ethos, MR-Linac, proton therapy, and now we have carbon ion. These are different words that you hear. But what I'm passionate about is how do we use radiation effectively, personalization of treatment, and that is on the right. We as a field in radiation oncology, let alone, just in cancer in general, have not really exploited this, especially in radiation oncology. Now, in medical oncology, you have a target, then you have a drug that target the lesion, the mutation. In radiation, we kill the DNA. However, we can exploit the DNA by thinking, what can we do with radiation? And the way to do that, we only can go either upward or downward, right? It's not like we have a different radiation. It's just really, can we escalate or de-escalate? So this morning, I would like to talk about, or night for you, how do we exploit this biology to more effectively treat our patient? And these are my disclosures. I'm going to go through putting everybody in this same page. What is the standard of care for HPV-driven oropharyngeal cancer? The most accepted standard of trial is still 7 weeks of chemoradiation or surgery, followed by post-op radiation to 60 to 66 gray. Now, with the ECOG trial, we have some centers have adopted 50 gray for intermediate risk patient. That's what we do at Sloan Kettering. But no matter what, their patients suffer acute and late toxicities. As a result, there are efforts by many people, whether surgeons, med-onc, radon, dental, rehab, on how do we de-escalate, because these patients are going to be alive, and we follow them and we'll realize, wow, there are late effects. And radiation is one of those things, once you give the patient, you can't take it back. And as you project long time down the road, you may have unwarranted late toxicity, such as osteoarterial necrosis, significant fibrosis, dysphagia. So we need to work on this. However, making changes to standard of care is hard. Right now, I think we're in a very confusing space. Depending on which center you go to, the treatment can be completely different. There are many clinical trials ongoing, whether phase 2 or phase 1, but really we need to make a standard of care change. Unfortunately, in the past 2 decades, it's not that we didn't try to do this, but all the non-selected, meaning just looking at HPV alone, de-escalation approaches have failed to date. And I want to talk about some of the lessons and then end by talking about what we're doing at Sloan. Remember, in 2006, cetuximab was the only FDA-approved agent in our space for locally advanced head and neck cancer. And there's no question it is a radio enhancer. However, when you compare to cisplatin, it is inferior. 2 phase 3 studies already showed us that. And even for low-risk HPV-driven cancer, the medical oncologists wanted to use this new drug, which is more targeted therapy, to perhaps mitigate some of the side effects and maintain survival. And we didn't do that, unfortunately. We can't. So nobody talks about cetuximab anymore. But when this drug didn't work, and given that PD-1 or immunotherapy is the current thinking for most disease, how about for HPV-driven cancer? Su Yam tried to do this in energy study, where we gave a single agent nivolumab versus platinum. And the results, unfortunately, also show that nivolumab was inferior to high-dose cisplatin. You can see the curve for 70 gray and high-dose cisplatin. It is going to be very hard to beat this curve. So changing the standard care is going to be very difficult. And we know that, when you give PD-1, there's an antagonistic problem with concurrent radiation. And this was our paper on Javelin, but I don't think it's a field size issue nor a fractionated issue, meaning that you need to give SBRT. There's a lot of buzzword. Now there are a lot of negative studies now, 10 to 12 positive, negative randomized study. There's a reason, and this paper is under revision. Hopefully it'll come out by Nadim and Tim Chan just to understand. And it has to do with the bacteria. It's in the tumor, not in the microenvironment, but tumor bacteria burden. The higher the bacteria content within the tumor, it will spill out to the microenvironment, and there's an antagonist effect with the concurrent administration of radiation and PD-1 or PD-L1 that is not seen with the control group. So the paper hopefully will be published shortly. We can contribute to the understanding of PD-1 in the setting of RT. So we know that cetuximab doesn't work. We know that PD-1 won't work. We're back to cisplatin. But then these tumors are very radiosensitive. How about we just drop cisplatin? Just give RT alone. Su did this study, inferior, as you see. We do need to have cisplatin. Okay, we can't drop cisplatin. We can't give cetuximab. We can't give immunotherapy. How about we keep radiation and just drop 10 gray, just 1 week of radiation based on UNC data and other data, phase 2 data. Su Young did this study again, very clean study, right? 70 gray with 2 cycles of platinum and then 60 gray with platinum. Again, shocking to our field, inferior. It tells you radiation dose does matter. So we can't drop anything. We're back to square one on 70 gray with cisplatin. So how about can we use technology to de-escalate? This paper will be out. Steve Frank ran a phase 3 randomized study comparing intensity modulated proton therapy with IMRT. We know IMRT gives you great survival, but look at the curve at when you follow this out, about 5 years and 10 years, they do separate. We don't quite understand why, but the fact is proton is keeping patient alive longer than IMRT. So we really have to think about, should we consider proton the standard care? So we're waiting for this paper. Now, until then, what can we do? There's one thing I do want the people to know is, as a radiation oncologist, when we say 70 gray, it is not everything getting 70 gray. There's a subclinical region. This is what we do at Sloan. We have a 2-phase plan. We know here's a base of tongue tumor to the lymph node, as shown in this coverage here, and tumor target here. We give first phase just 30 gray subclinical, 2 gray per fraction, and then we boost just the tumor. So you can imagine the toxicity is dramatically low. And we published this paper, Julian did, and you look at this tumor. And what I want to point out is, depending on where you go, this subclinical dose is all over the place. There is no standard here. And imagine you've gave the constrictor 63 gray, you're not going to swallow, versus 30 gray. Our data shows very high survival, and there's an update at ASTRO with median follow 64 months, similar data. And they'll be presenting ASTRO this year. And now Energy Oncology is going to do a phase 3 randomized study comparing 30-70 versus the standard 50-70. And there's no doubt in my mind that this will be in favor of the experimental arm, because just think about it. Why do you have to cut the same amount, if you're a surgeon, tumor as a normal tissue? So similarly, why do I need to radiate the normal tissue to close to 70 gray when I can give lower dose? And also upgrade trial, RT alone without HPV status mandate, without that 34 gray, if you do the B calculation, was sufficient for a subclinical dose, and that's RT alone. So think about it. That's similar to, and we give chemo, and this is HPV, so it is absolutely safe in my mind. So in summary, for all these studies, I said a lot of negative trials, but even in the standard, it's still very high doses of radiation. More importantly, we don't know why a patient failed, because we need to have tissue. We need to understand why. And this is why I want to talk about, do we need to treat everyone the same? Does one size fits all? We know it doesn't. Here are 2 major approaches that we have at MSK toward de-escalation. First, a surgical approach, robotic surgery. Can we use, the hypothesis is, ctDNA to detect the MRD state so that we can guide adjuvant therapy, just like what we do with prostate cancer? We don't give post-op RT for prostate cancer after prostatectomy if the patient has an undetectable PSA. So we did this trial with Mark Cohen, Linda Chen. We have, of course, a pretreatment positive value, ctDNA, and this is a commercial assay that we use, and surgical resection of all growth disease. We need to have an indication for radiation. We then repeated the assay 2 to 4 weeks with 2 time points. Plus, we had an MRI in our department to make sure there's no growth disease. And then we had an algorithm. If you continue to be negative, undetectable, surveillance. If you are positive, delay adjuvant radiation. But if you're off study, if you have growth disease. To our surprise, with this, we had 67% that can be omitted radiation, but 25% growth disease came off study. And then here is an example. Someone was 1608, dropped to 0, continued to be 0, but at 6 months, still 0, positive node. And so we don't recommend using ctDNA to guide therapy. Dr. Carol Thackeray talked about Dan Fagan's group, and we also have our group with more personalized cell-free DNA, but that's great. We still have to connect the study. My understanding MGH does, but the current thinking is really to combine it with pathologic feature. And then pose the question, do we really need additional cell-free DNA to tell us what to do? So the jury's still out. Now I'm going to end by talking about non-surgical approach, which is what I'm very passionate about. Can we personalize and de-escalate therapy and achieve the same outcome? I want to bring everybody back to hypoxia. Everyone knows hypoxia is bad. Throughout all cancer sites, preclinical, clinical, animal, it's not good. It just means low oxygen. You need more radiation dose to help with hypoxia to overcome radioresistance. Hypoxia is also important for HPV-driven cancer. Call your attention to this study by Dr. Schwartz. HPV-positive tumor, if you're non-hypoxic, measured by HIF-1 alpha, you do well. But look at this group, HPV positive. If you are hypoxic, you didn't do well. You are just like your non-hypoxic HPV negative tumor. So if you're going to de-escalate, you're not going to de-escalate patient with hypoxia. And that's what we did. Hypoxia, how do you measure in the clinic? Non-invasively. Because you're not going to put a probe in. There are many tracer. All of this very small studies. We decided to go with F-MISO, being around for 30 years, scanned over 1,000 people worldwide. It is safe. Here's an example. FDG positive, F-MISO negative, 30 gray, doing well. FDG positive, F-MISO positive pretreatment, and it converted 30 gray. How about FDG positive, F-MISO positive? There is still, it's not showing as well. You see a signal here. Do not de-escalate. We go to 70 gray. We then realize our decision-making actually happens at week 2 during chemoradiation. So we actually perfected our study. We've done over 600 patients. We do not do the pretreatment. Make it very simple. We publish our data. We had a pilot study, 19 patients that was published in JNCI. Then we continue on. We use F-MISO as an integral biomarker, meaning that we actually make change, not integrated, but we'll make a decision in the clinic based on this image tracer, larger cohort. We still remove the primary disease that we didn't care about margin status. This is really because of the NIH funding. As you know, in radiation oncology, we don't get funding. NIH wanted us to take the tumor out. Didn't care about the margin status, but we took out the planned neck dissection. We had 158 patients. We were able to de-escalate 128 patients, about 80%. Look at our curve, 2-year progression-free survival, 94%. We had 1 person fail local region distantly. Survival is excellent. In fact, only 1 person died in the 70 grade cohort. Then we wanted to expand our experience outside MSKCC because our goal is changing the standard of care. As I said, it's hard. It's not an easy road. We met many roadblocks, but nonetheless, we continue on. We expanded it, the next cohort, 158 patients. We de-escalated 74 patients. We no longer require surgery to the primary. These are your T1, T2 tonsil, basal tongue tumor, and plus no positive disease. We have about 20% N2C, bilateral neck disease. No surgery to the primary. We tested the feasibility outside of MSKCC. We had people go generate the tracer. We went to our alliance partner in Miami, Hartford. Look at our data. Survival is excellent. And then the toxicity difference you can see to a point where NINJM Journal Watch said, this is all great what Memorial's doing, but we need a randomized study. And of course we are. We went to the FDA. We have this ongoing, about 50 patients now out of 291, 2-to-1 randomization. Here's your inclusion criteria. Surgery is not needed. Personalized pathway or standard care of 70 gray with 3 cycles of platinum. Double-blinded study. I don't know what the hypoxia status, neither the patient. Nuclear medicine doesn't know either, so we keep it very clean, double-blinded. The only time we will know in week 2 is the research assistant will call us and say, oh, stop at 30 or go to 70. Now, you can't blind radiation, one can't give sham radiation. So the only time you will know that you went on the experimental arm is if you stopped at 30 gray and you're hypoxic negative. You can go back on inference, but we will never say that. You need the PET read, reproducible. We completed this study of over 5 licensed nuclear medicine doctor, because remember, we want to bring this to the standard care. If positive, FDA will approve this, just like PSMA PET for prostate cancer. Primary objective is survival with a series of secondary objectives. And we model our stats calculation with our TOG study. How do we produce? F-MISO is easy. It's just like FDG. It's a tracer that we buy from General Electric. You need a cyclotron, out come your tracer. As simple as that. People made it so complicated. And in our study, only one PET scan. And this study is being done now in Sydney, Australia, and at NSW, and will open in Germany. 30 gray is very binary. 37, how about in the middle? So in my mind, toward personalization, this is where AI comes in. We can't do this as a human. Lots of personalization. This is what I think. HPV positive, I think only 10% of the patient needs 70 gray. 70% get your 30. Then you divide using AI model. I think there's a group of patients, 20% needs 36 gray, another 10% 70 gray. So therefore, I think HPV is not driven by smoking status. In fact, we're going to have a paper out that Brian Sullivan team going to do. Smoking is irrelevant for local region control, maybe for survival. We're going to divide into low risk, intermediate, high risk, and we're going to use hypoxia to do that. In summary, I want to bring home a message. We need to do biologically driven precision radiation. It's not an easy road, but this is the beginning. I like to transform the practice of radiation oncology from an empiric blunt tools to one that is using biology information as a targeted approach. Do we escalate? Do we de-escalate? How much to de-escalate? This work cannot be done without a whole team behind me, and thank you for your attention.
Thank you very much, Professor Nancy Lee. That's a great talk, and then giving us quite an eye-opening for the new hope for the treatment for the de-escalation. I hope that you can stay a bit during the panel discussion. We can maybe some question about this, and we can touch base on the treatment. Okay, thank you, and let's move on to the panel discussion. So this part, we're gonna have the 3 speakers to share their insights on the HPV-related oropharyngeal cancers from different countries. Start from the first speaker, Professor Cheng Po Hao. I would like to take this opportunity to introduce him. He is the professor of otolaryngology and neck surgery at Shin Kong Wu Hosu Memorial Hospital, and he's a global leader in head, neck, and scalp-based surgery, and also a researcher. He's a past president of multiple regional societies, and one of the most importantly, he's the founding president of the Asian Society of Head and Neck Oncology. So he's going to talk about the HPV-related head and neck cancer in perspective of the Asian. So please, Professor Cheng Po Hao.
Yeah, thank you, Peter Booth, for your kind introduction. And so in the following, I'm going to share with you just a very simple questionnaire survey on HPV-related oropharyngeal squamous cell carcinoma under the body of the Asian Society of Head and Neck Oncology. And so we have in around 4 years ago, we did this study on 14 countries and give them questionnaires and to ask them the instance of the HPV positive oropharyngeal squamous cell carcinoma out of the all oropharyngeal squamous cell carcinoma, and there were 21 responders, and so we roughly group the 14 countries and 21 responders into the developing level of the country. So we have developed countries such as Taiwan, Japan, Korea, and Singapore, and developing countries, Malaysia, Thailand, Philippines, India, Indonesia, Vietnam, and China, and underdeveloping country, Nepal, Myanmar, and Bangladesh. And we are very interested in how the HPV, positive cancer would, presented in the, the percentage in the oropharyngeal squamous cell carcinoma, and also how in different countries how we would treat this disease. Next. So the result here, I just read the results. So 76% of the country have actually national HPV screening program, and so that's basically for female. And 91% of the countries have HPV vaccination, but only 43 it's a national program, and mostly the program was for female. And the vaccination program is provided mostly for female, actually no male. And in nowadays, there is no mandatory for the male to have HPV vaccination in any of the Asian countries. And so for the OPSCC instance, male is higher than female. We all know that because in our region, the betel nut chewing and smoking is pretty high, instance is pretty high, and then that really affects, the conventional oropharyngeal squamous cell carcinoma. And and then we realized that the HPV-related oropharyngeal squamous cell carcinoma would be more in developed countries, and which could be as high as 40 to 50%. And I think later on, Japan would talk about this because in our study, Japan would be the highest instance of HPV positive related oropharyngeal squamous cell carcinoma in the Asia. And HPV related oropharyngeal squamous cell carcinoma instance is actually parallel to the developing level. So we just compare the HPV versus non-HPV positive, HPV positive versus HPV negative OPSCC. In Japan, the instance, Korea and Singapore, the instance is above 40%. In Taiwan, it's around 30 to 40%. In Thailand, the so-called developing country, Thailand, Malaysia, India, Vietnam is around 15 to 20%. In others, the underdeveloping countries, the instance would be less than 10%, or even some don't have any reported instance. For example, in China, in Philippines, Indonesia, Nepal, Myanmar, or Bangladesh. And so the conclusion for the questionnaire study is that the survey indicated that the higher instance of HPV-related oropharyngeal squamous cell carcinoma in more developed countries, and which is roughly, the instance is roughly parallel to the economic development. For example, you could see on the right lower part, you could see if we compare the economic development with the HPV positive instance in the oropharyngeal squamous cell carcinoma, you could find in the more developing country, economically, they would have higher instance of, HPV positive oropharyngeal squamous cell carcinoma. It seems to be it's actually an indirect evidence that this is actually a sexually transmitted disease, so that in the more developed country, that people might have more sexual activity, and then the instance of P16 positive oropharyngeal cancer instance would be higher. And we also noted that in our region, there is actually no routine HPV test. And then the HPV status has been ignored even in some countries. And And then there is even no vaccination program, and for some of the country, no national program for female. And then there is no mandatory, vaccination program for male in our region. And there's also a culture or religion, a lower playing behind because in Asia, people being more conservative or suppressed sexually. So that will be my presentation. And so the HPV positive oropharyngeal carcinoma is really related to the economic development. Yeah. Thank you.
Thank you very much, Professor Sheng-Po Hao, to have a different view in the HPV in Asian countries. So then we move on to hear from from Japan, that Professor Sheng-Po Hao just mentioned, that has the highest prevalence of HPV. And Professor Yuki Saito, he is an associate professor in the Department of Otolaryngology at University of Tokyo, and he's among the researchers in several landmark study in Japan. So today he's gonna talk about the HPV-related OPSCC management in Japan. So please, Professor Saito.
Thank you very much for the kind introduction. Can you see my screen?
Yes.
Yes.
Yes, thank you. It's my great honor to be here today. My name is Yuki Saito from the University of Tokyo, Department of Otolaryngology and Head and Neck Surgery. Today, I'd like to talk about the current management of HPV-related oropharyngeal cancer in Japan. I have no conflict of interest to declare. So Professor Franklin and Lee provided more detailed explanations of HPV-related oropharyngeal cancer, but I will summarize them briefly here. HPV-related oropharyngeal cancer occurs mainly in the oropharynx in the head and neck region, especially a tonsil. In daily clinical practice, we usually use P6 immunohistochemistry as a surrogate marker for HPV status. Although it is not a direct test for HPV, it is widely accepted for clinical use. According to a recent study by Nibu et al., the sensitivity of P16 positivity for HPV infection was 97.8%, and the specificity of P16 histochemistry for the HPV infection was 94.2%. So, and compared to the HPV negative OPSCC, HPV positive, P16 positive cases are characterized by occur even in patients who drink little alcohol and smoking. And P6 positive is thought to be originated in the tonsillar crypt. And it's likely to metastasize to lymph nodes when they are very small to primary, and usually respond to curative treatment, especially radiation therapy. In Japan, the P6 positivity accounts for nearly 60% of OPSCC, with reaching 70% in the lateral wall. So this is the result from the Japanese head and neck cancer registry. From the calendar year through the 2018 and 2020, the P6 positive rate is about 54.4% and 53.7%. And you know that the unknown status of the P6 positivity rate is declining. And about the subsite distributions, the lateral wall, that is the tonsil, the P6 positive rate is a success, about the 70%. In our data from the University of Tokyo, we have seen an increasing trend of P6 positive rate since around 2010. You see that the red bar is the P6 positive and the black bar is the P6 negative. When comparing the P6 positive and P6 negative, we found that P6 positive patients tend to drink and smoke less, and have tumors surrounding more from the lateral wall. Interestingly, there is no significant difference in age at diagnosis between p16 positive and p16 negative cases. When we look at age at diagnosis, the distributions of the p16 positive and p16 negative look similar. However, when we analyze birth year, we found that patients born after the 1950 are more likely to be p16 positive. This suggests that lifestyle changes over time, especially related to sexual behavior, have affected the prevalence of HPV-related cancer. This is how we typically examine patients, by pulling their tongue, and we will use the endoscopy for the evaluation of the cancer. Anyway, can you find the carcinoma in this image? This image shows the mucosal irregularity in the upper pole of the right tonsil. Narrowband imaging helps visualize such regions more clearly. So this is a movie from the real clinical practice. So many HPV-related cancers first present with cervical lymphadenopathy without an obvious primary tumor. So we must look very close to the tonsillar region, and this is the tonsillar crypt, its formation of the cancer. At our hospital, we follow guidelines from the NCCN guidelines and Japanese Head and Neck Cancer Society. For P60 positive oropharyngeal cancer with limited disease, we perform transoral resection and neck dissection without adjuvant therapy. For other cases, chemoradiotherapy (CRT) remains the mainstay of treatment. In Japan, transoral robotic surgery (TOS) is rapidly spreading over across Japan. As you see in this image, the robotic view provides more detailed visualization compared to conventional endoscopy. Surgeons perform precise procedures like suturing, enhance dexterity and 3D vision. So I think this platform is very good view and very secure transoral resection for the oropharyngeal cancer. In cases where CRT is required after surgery, such as where margin is positive or external extension is found, the total treatment intensity becomes very high. For these cases, starting with CRT may be more appropriate for ensure definitive treatment. At our institution, the 3-year overall survival rate for definitive treatment is close to 90%, even in a stage 3 advanced disease. But CRT is not perfect. Late adverse effect can significantly impact quality of life. This slide shows that examples of severe complications, such as shoulder aneurysm and mandibular osteonecrosis after the CRT about 5 or 6 years. This is why we need to develop less intensive treatment strategies. This is a presentation highlight. So in clinical practice in Japan, P6 overexpression is used to diagnose HPV-related oropharyngeal cancer, as P6 positive oropharyngeal cancer accounts for 60% of oropharyngeal cases. P6 positive oropharyngeal cancer has been on the rise since around 2010, with high incidence among patients born in the 1950s or later, and an increasing number of cases occurring in older age groups. NBI is used for diagnosis, and transoral robotic surgery is a good option for T1, T2, and 0, NB1, while CRT is the standard treatment for advanced cases. However, there is room for development of the intensified treatments in the future. Thank you very much for the attention. If you have any questions, please feel free to contact me in the email below. Thank you.
Thank you very much, Professor Saito. We're gonna come back to you again during the Q&A session, and you touched base a little bit about the robotic, but this time we're gonna have the last speaker for the panel discussion, Professor Yun-Woo Go. He's a professor and chair of the otolaryngology at Yonsei University, and certainly he's a pioneer in robotic and endoscopic surgery. Maybe he's the highest volume surgeon experience for the robotic surgery in the world. It's a great honor to hear from you about his perspective on the concepts for the HPV positive oropharyngeal cancer treatment. Please, Professor Yun-Woo Go.
Thank you for your kind introduction. Can you hear me?
Yes.
Okay. So I'm Yun-Woo Go from Yonsei University, Severance Hospital, South Korea. Today I'm gonna mention changing concept in the intensified strategy, especially for HPV positive oropharyngeal cancer treatment. I have nothing to disclose in this presentation. So today I'm gonna speak about the intensification in HPV positive oropharyngeal cancer treatment. I'm gonna mention three specific concepts. So first, the current concept, the intensification strategy. This kind of intensified strategy would be based on the ECOG 3311 study. So this kind of study already mentioned Professor Nancy Lee, and but as a head and neck surgeon, so currently the intensified modification for treatment of HPV positive oropharyngeal cancer would be based on the ECOG 3311 study. So this, in this study, after transoral robotic surgery, every patient would be divided into the different 4 groups. So according to permanent pathology. So arm A is negative margin, N0 or N1, no external nodal extension. And arm D, this is a high risk group, positive margin. So over 1 millimeter external nodal extension and more than 5 positive lymph node metastasis. So should belong to arm D. So these patients would be treated with post-op chemo radiation. Radiation dose is quite important in this study. So arm D, 66 gray radiation should be given, but even intermediate risk group, arm B, they would be given with 50 gray. Now I'm going to mention about the intensified surgery. So long years back, Professor Weinstein developed and introduced the transoral robotic surgery for oropharyngeal cancer, especially base of tongue and palatine tonsil cancer. So nowadays, worldwide phenomenon. So transoral robotic surgery, the number of surgery would be increasing very steeply, very rapidly. But nobody mentioned about neck treatment by surgical intervention. So we can treat the intensified pattern with transoral robotic surgery, but still, in aspects of neck treatment, it means neck dissection should be done with conventional incision and conventional technique. So not only disfiguring scar, most of patients would suffer from post-op lymphedema, especially in case of radiated patients. The suffer from the post-op lymphedema. Probably this kind of lymphedema would arise from blocking the lymphatic channel of a subcutaneous layer, I think. So if you're gonna do retroauricular robotic neck dissection, we can achieve the real intensified oropharyngeal cancer surgery. So for primary treatment, we can use transoral robotic surgery. At the same time, we could use the retroauricular robotic and precision neck dissection on the 10 times magnified robotic view. So we could achieve the real de-intensified oropharyngeal cancer surgery. And then, according to permanent pathology, we could de-intensify post-op adjuvant therapy. This is the example. This lady had tonsil cancer, left side. So primary, the tumor was excised with the transoral robotic surgery. Before performing transoral robotic surgery, we could do modified radical neck dissection, including level 2 to 5. So permanent pathology revealed the single lymph node metastasis, no extranodal extension. So in this case, we could choose the surgery alone strategy without the post-adjuvant therapy. So she's doing well. So I think this is gonna be the typical example, the intensified treatment in the intermediate and low risk oropharyngeal cancer with HPV positive. And nowadays in our the head and neck multidisciplinary team, so we are performing very kinds of neoadjuvant chemotherapy clinical trial. So if you're gonna performing neoadjuvant chemotherapy followed by the intensified surgery, we could achieve the real de-intensified treatment in HPV positive oropharyngeal cancer. For example, we already finished the enrollment of HPV positive oropharyngeal cancer. So we call it genuine, and we call it NEOS. Another study is the MK study. So today I'm going to mention about genuine study. This is a very interesting study. So HPV 16 and 18 positive, but verified with the HPV RT-PCR. And in this group, we before surgery, we're gonna use the HPV DNA vaccine and interleukin 7 and the checkpoint inhibitor pembro. So the 3 drug must be used before surgery. So in this study, we enrolled 11 patients. So 2 years back, in ESCO meeting, our study could be presented in poster. So neoadjuvant immunotherapy of pembro combined with therapeutic HPV DNA vaccine of GX and long-acting interleukin-7 for patients with resectable HPV positive head and neck squamous carcinoma. So as I told you, we enrolled total 11 patients. Very interestingly, before neoadjuvant chemo, clinical T stage T4, but the permanent, the pathologic stage T0. So among 11 patients, so total 4 patients so converted to pathologically T0. This is one example, oropharyngeal cancer base of tongue cancer, GP circus origin cancer. So MRI scan revealed the T4 cancer and one oropharyngeal P16 positive tongue-based oropharyngeal cancer. This is the initial MRI imaging, and after the news of the chemo regimen, so we could see the partial response over 50%, but still radiologic residual disease would be there. So we conducted robotic neck modified radical neck dissection, including level 2 to 5, and then the transoral robotic surgery has been used for extirpation of base of tongue cancer like this. This is a surgical specimen, neck specimen, and primary tumor specimen. This is a pathologic slide. Very interestingly, just before surgery, we checked MRI scan, neck MRI scan, so we could verify the still residual disease, radiological residual disease already verified, but in the permanent pathology, no residual carcinoma has been reported, and resection margin free, and among 27 retrieved lymph node, no metastatic lymph node has been revealed. So we discuss in our multidisciplinary team discussion, so we decide not to add a post-adjuvant therapy, even initially T4, clinical T4 tongue-based of cancer. So this is the pathology. We couldn't see any evidence of viable squamous cell carcinoma. So in this case, we could know so radiologic response and pathologic response is not the same in every case. So this is a poster. So right side the base of tongue, big size. So without the disfiguring scar, so nobody knows his operation history, and owing to neoadjuvant chemo strategy, so he didn't have any post-adjuvant therapy, any chemo, any radiation therapy. So nowadays we extended this kind of genuine study. So already finished our enrollment. About 45 patients enrolled in this study, but in this extended study, we divided into 4 different cohorts: cohort 1, cohort 2, cohort 3, cohort 4. So in especially in cohort 4, we didn't add immune checkpoint inhibitor, pembro. So very preliminarily, we could get some impression. Cohort 1 and cohort 2 is the higher instance of the partial response. Sometimes complete response would be seen before oropharyngeal cancer surgery after the neoadjuvant chemo strategy. So sooner or later, we're gonna report our the result. So I hope the promising strategy would be found in this kind of study. Thank you for your attention.
Thank you very much, Professor Go. I think we have learned a lot from different perspective over the about the HPV-related oropharyngeal cancer in the Asia Pacific. Time is quite limited, and we have several questions over here. I hope that the speakers and panelists may respond to this question. Maybe I will try to bring the question that may relate it to what is the different to compare what's going on in the Asian country and North America, and also may relate it to the question right here. And maybe what do you think that why the HPV related oropharyngeal, the proportion of HPV is quite a difference in in the Asian sides, in many countries in Asia, in comparing to the North America. I'm not sure that Carol is still here in terms of epidemiology.
Yeah, it looked like Shangpo wanted to answer, so go for it first.
Oh, okay.
Muted. So you're muted. I can see you try and talk, but you're muted.
Okay. So based on our survey, I think the HPV positivity is really related to the economic, development, and so roughly related to parallel to the economic, and that's probably because of the more sexual activity in the developing country, which has also been proved in Japan, as they have increased incidence after I think 2010, if I remember. And so that basically, and especially for young generation, and there were higher instance to develop, HPV positive oropharyngeal cancer. So I think it's maybe related to it's just a sexually transmitted disease and just related to the economic development. I don't know, Carol, what's your opinion on this?
Yeah, I would agree with that. I think there's several lines of evidence that it is related to economic development or and sexual practices. I think that there are other cofactors that have yet to be elucidated, and I think that's where natural history data will be very important for us to understand. So, in among people who are exposed to smoking, might we have increased likelihood of a persistent infection, and other environmental factors. So I think we'll have more information over time on that, but I think that there are probably several cofactors when we consider why some infections persist, because I think in all earnestness, these are all common practices, and infection is very prevalent, and so exposure to infection is very prevalent. And so there might be a part that has to do with increasing frequency of infection and exposure to infection, but how do we get from infection to the rare event of cancer is, I think, still poorly understood.
Okay, thank you for your, yes?
Well, I was going to add, I think it's as stated, sexual behavior. I think in next decade, you're going to see the Asian countries with the increasing rise of HPV-driven cancer. I remember even maybe like 5-6 years ago, it was rising in the United States, but when you go to the Asian countries, they're like, we don't have any. And recently I was taught it's really a change. whereas in the past, oral sex was not performed among the Asians or outside the United States, is becoming increasingly popular. So that behavior change. So we're going to see the rise. And you can see in Taiwan, it's 30-40%. It wasn't like that many, many years ago. And you see Japan 40-50. And I think it's going to continue to rise. And in China now, too, it's increasing in incidence. So that's what I think we're going to see.
Thank you very much for your view. Well, its time is quite, come to an end. I would like to really hear from you all, but please give only 1 or 2 sentences that what is your next step that would you do, in terms of whatever prevention, management, research, or in your own role or in your own context toward the HPV-related oropharyngeal cancer. Just leave it as the final sentence for to close this session. You understand what I'm asking? Yeah? Okay. Maybe Nancy can start.
Well, yeah, I have a role. I'm going to complete the phase 3 trial, bring Epmyso to FDA indication, and then everyone in the world can use it. And that is why I'm doing not only United States, I'm helping Australians and Germans to do it. It is a great technology. Hypoxia is important not only for HPV, it will be applied for all disease, just like FDG. The indication of FDG was actually colorectal cancer to liver met, but now we use FDG like water. And that's what we're going to do for Epmyso and help de-escalate or escalate.
Thank you, Nancy. Carol?
My
Just
hope in
couple
my
of
remaining years
sentences.
I hope in my remaining years of my career are to develop a screening paradigm to detect HPV-related oropharynx cancer earlier, so we can reduce the morbidity and mortality of it. So.
Wonderful. Thank you. Professor Cheng-Po Hao?
Yeah, I might just try to push the, vaccination, especially for male. I think probably in 10 years, I don't know if Carol agree with me or not, probably after we push the male vaccination, probably in 10 years, we might see the decrease of the HPV positive oropharyngeal squamous cell carcinoma instance. Yeah.
Wonderful. Thank you, Professor Cheng-Po. Professor Saito?
Yeah. In Japan, the vaccination rate are so low, so I believe that the first priority is to promote HPV vaccination for girls and boys for prevention.
Thank you. And Professor Yunwoo Go, what is the next step you will do?
Okay, in aspect of prevention, vaccination is I totally agree with Professor Cheng-Po and Professor Yuki Saito. But more importantly, nowadays we're gonna focus on early detection. So I'm quite impressed at Professor Nancy Lee ctDNA for early detection of recurrence. But not only recurrence, but new patient should be diagnosed in early stages. So I think that is an important strategy in near future.
Thank you very much. That is a real personalized approach for the oropharyngeal cancer that has made by the HPV. And I would like to take this opportunity to thank you all the speakers, Professor Farki, Professor Lee, Professor Hao, Professor Saito, and Professor Go for your wonderful contribution for this session, make it very successful. Also would like to acknowledge Jonathan Umansky, who behind the scenes supporting us with all the technical issues that make it run so smoothly. And it's not the end of about the head and neck oropharyngeal cancer, because I would like to invite you all to join the IPVS conference 2025, which will be held in Bangkok, 23rd to 26th of October. Please save the date. And we're gonna have plenty of sessions, cervical cancer and all kinds of cancer, and certainly the head and neck cancer. We have the, forum, the whole day that contributed to this kind of cancer. So please join us. And the registration still early until the end of this month, and also the late breaking abstract submission is still open. So please stay tuned, and we'll see you in October. Yes, and this is upcoming IPVS webinar. So please join in September the 9th, Rethinking Age Cohort HPV Faster proposal to reach cervical cancer elimination goal faster. So thank you very much, and everyone to participate in this webinar and to receive the CME certificate. So please, stay tuned, and we shortly be directed to the post-webinar survey to claim your CME. And please join us in the IPVS through this QR code. And so now, hope you have a good day, good night, and see you soon in IPVS in Bangkok. Thank you very much.
Bye.